procedures am I currently using the diode for? I'd say your bread and butter procedures are your gingivectomy for bracket placement and access to placing brackets accurately. To me, that is the #1 advantage, day in, day out advantage of the laser. We do not compromise bracket placement in our practice. This is where we gain great efficiency by looking at a case ahead of time. For instance, in my exams, we have a probe and we check for passive eruption, tissue that's being brought down by erupting bicuspids, and we all know those second bicuspids are sort of the bane of orthodontics. We're trying to get the braces on, the teeth are just coming in. So this is an opportunity to get all the brackets on at once and have good access for it. So gingivectomy for bracket placement is a big one. Perculectomies are routine, canine exposures, routine stuff. Maxillary frenectomies at the end of treatment for us are sort of the bread and butter. If you're talking about advanced procedures, the most fun procedure we do is a cosmetic recontouring. So if you take the upper anterior 6 teeth at the end of braces for somebody who has a lot of hyperplasia, they'll be really proud of their smile, as you'll see in the later videos. A video for hygiene. This particular case actually has pretty clean teeth, but you'll notice for patients that aren't in the habit of flossing, they'll get the papilla that pop up from time to time, and they have a question about, what do I do about this? What I'm doing actually is an internal beveled incision to simply lop off the top of that papilla. And if you had to describe it specifically, I'm coming from the base of the papilla. If you imagine the papilla like a triangle, it came from the base first, and I aimed at sort of the contact point. So all I'm doing is cleaving off the top of the papilla. Now I'm just shaping up the sides of that so that it's good. Okay, that's a good picture to just look at as we finish up this video. Now that's a neat thing to do for a patient, and it's simple, keeps everything clean, and they're proud of their smile, and their parents like that when you help them out in such a way. This is a neat procedure coming up, and it requires that I give you a little history on this patient. The patient had a powerfully impacted maxillary left canine, and you're looking at the upper occlusal view, I guess that's my operator's view. And in this case, the patient had an infection following the exposure, and we weren't able to begin doing the treatment. And so the chain, it basically healed up at the crest of the ridge, because as the surgeon just tied that chain to the lateral incisor. Well, the canine's down in the palate. This is one of the deeper, more horizontal impactions you'll see from time to time. And so rather than send the patient back for another procedure where they already had a problem one time, I can use a laser that sterilizes as it cuts, and I can literally be putting a light tension on the chain. This is a gold chain attached to the permanent canine, and we were able to document this really nicely with the 3D views that we're getting on the cone beam CT and know exactly where we were going. But you see how many links of chain would it take to have just drug that chain through the tissue. It would have been months of treatment just to get the chain taut, because I needed to pull this canine away from the roots, or lingual to the roots of those incisors as a first step, and then to extrude the tooth first, and then do it labially. Had I just pulled from where the chain came out, the risk of resorbing the roots of those anterior teeth. So with the 3D views, I was able to determine the strategy, and then with the laser, I was able to execute the plan without any help. So that turned out to be just a win-win for us and the patient, and a neat advanced use of the laser. A lot of people are interested in what the patients think about the laser and what's the post-op reaction for the patient. It's a little scary for a patient to hear about lasers. So we include the informed consent in all of our consent forms, and so that when we do have to approach a patient about laser, we're not getting paperwork out and having to get things signed at that time. We did it ahead of time, and we take time to explain it at that time. But the patients are a little nervous at first when we show them some cases and things like that. It's good to have some pictures or some videos or anything you might show them. But the kids think it's pretty neat. And then when you tell them you're not going to have to give them a shot to do that, it's even better. So we talk about using topical anesthetic, and of course the post-op is a no-brainer. There's really very little risk. We've never had a case of infection. We've never had any real post-op pain. We've had patients that literally go eat Mexican after the procedure. They told us they went out to eat Mexican food or salsa after the procedure. So indirectly, I guess you create a Band-Aid during the course of the treatment. And the laser, as I mentioned, sterilizes as it cuts. So post-op experience is a wow. It's a fantastic procedure to be involved with because there's very little, problems post-op. We're moving on to one of the more common things we do. We've got anesthesia with the topical anesthetic here, and we're checking that with a cotton plier as we begin our maxillary labial frenectomy. Now, the starting point for labial frenectomy is not at the tip of the papilla. It's at the insertion of the frenum. So you can notice I'm sparing the papilla in the midline because we don't want to generate any heat there. We don't want to have any crestal bone loss from any heat. So it's a surface procedure, and we're working right along the long axis of the alveolar ridge, and we're just working back and forth. I'm keeping some light tension on the upper lip, and as we work our way down through the epithelium, you'll see that characteristic diamond-shaped pattern coming up that's typical for most frenectomies. Our goal in this procedure is to detach the connective tissue fibrils that dive through the frenum that support that epithelium. And in those cases, when we hit the white connective tissue fibrils, we'll have to increase wattage, as it mentioned there, sometimes in an effort to get through those fibrils. Otherwise, you're strumming those banjo strings, so to speak. They don't cut. So, and the patient might be sensitive to that. We're doing this procedure all with topical anesthetic, and we'll move right to the finish of that procedure to show you how clean that is. There's no carbonization if it's done right, and just almost innocuous procedure for the patient. I have to tell the patient to keep their lips separated in the vestibule by blowing air under their lip or pulling their lip out so it won't heal back on itself. But you and I know we've got the connective tissue fibrils cut, but the patient just sees that it draws up or heals down. They don't think anything was done. So it's important to keep it separated for about 24 hours so surface tissue will heal up. As a final question here, people are interested with referring doctors and periodontists as to how, in our community, how did that go over. I'd say, the dentists feel like it is high-tech, and they're seeing a lot of uses for lasers, too, with, working through the sulcus of the crown prep, exposing that margin for a good impression. They see the value of doing that. The periodontists are not on board with this necessarily. Some are and some aren't. So you got to be careful about stepping on some toes, but that's just like the way we feel about a GP doing ortho, or maybe a periodontist doing implants. That's how the surgeons feel about that. There's a lot of overlap. So, I think if you take time to learn these procedures, do a good job, I don't think anybody's going to have a problem. You're saving your patient a lot of trouble. And it's, I think, a very positive thing in the end. Again, this is a pretty tough procedure to see well, but if you get good isolation, to quickly, I guess, get to it, I would advise staying off the distal buccal. Usually the keratinized tissue is not available off the distal buccal of a second molar. There's a very thin band there. So usually we'll start on the distal aspect and work our way around exposing the tooth. You want to get this in one bite. In other words, a lot of these, if you can't flow the topical underneath the flap of tissue and get anesthesia from both the top and the underside, then you may have to give anesthesia for these fibrous frenums, or if the entire tooth is, covered, certainly I would get anesthesia for local anesthetic. In our course, we get a kick out of everybody wanting to know the individual settings for certain procedures, but it has so much to do with the tissue type. It has so much to do with the quality of the anesthesia. It has to do with how well the tip is initiated. All I can do is just give you a ballpark, but we generally want to use the most conservative amount of wattage that cuts efficiently for us. And you work in lasers, you always work from low to high. You want to start out and see how well you're cutting, for instance, at 1 watt. But a well-initiated tip for a healthy tissue or even inflamed tissue for a gingivectomy at 1 watt is I'd say typical, we might go to 1.2 watts. Generally speaking, not over 1.2 watts. The wattage that I was doing for most of those procedures that were healthy tissue, that's thinner tissue, not that fibrous, would be in that range. Occasionally, we'll have a thicker tissue, more fibrous tissue wanting to get through quicker. You've got anesthesia in the area, for instance, and we'll cut those up to 1.4 watts. But that's a good, clean procedure to do. Doesn't take a long time. It heals up well, and you're, again, ready to go as far as the patient's ability to clean it, or if you want to seal the tooth or have the tooth sealed, that's ready to go at this point. How many patients do you ever see as they come out of braces that need, months of good hygiene now to get the tissue back? And you look at, your patient before treatment, they look like this. You don't know who's going to brush their teeth and who's not. This is her at the end of treatment. This is actually when we're getting ready to deband her case. It's not always what you expect. And it's a sad statement of affairs, but we're always racing to the end. The parents want the teeth done right. We're battling the hygiene issues. And if you look, these are just swollen papillae. These could have been cleaved along the way. We're at our deband, actually, and we were pushing right to the limits getting this done. This is what she looks like when she comes right out of the braces. This is actually a patient we saw at one of our courses, and in a live patient course. And so she was debanded at the course.